Welcome back. We are picking up from the earlier session on episode of care and the episode-oriented medical record. If you haven't watched that yet, I would recommend doing that first. In this session, we'll focus on data modeling, how to represent Solon's episode-oriented medical record in openEHR. This is based on my masterclass thesis, and it summarizes the key modeling approaches. Let's briefly recap the big picture. We are looking at the high-level organization of the episode-oriented medical record. Care can be structured along three dimensions: organization, time, and content. First, the organizational dimension is the care encounter. Solon calls this a contact. It's a single interaction with a healthcare professional at a specific time and place. Second, the temporal dimension is a period of care. It groups what happens within a defined time window. Third, the content dimension is an episode of care. This is one distinct health problem or diagnosis. Clinical information is captured as medical record entries, and each entry is linked to contact, a clinical section, and an episode of care. The episode list can be generated automatically. It's a linear list of all episodes for the patient, meaning all recorded problems and diagnoses. On top of that, the diagnosis and problem list provides a hierarchical view by grouping clinical related episodes. This is the architecture we will now model in openEHR. Why does this architecture matter? An episode of care fits modern clinical documentation because it captures the patient course over time and across settings. Each episode represents a single problem or diagnosis, and it gives you one clear source of truth. Care encounters or contacts are the smallest clinically meaningful unit. They group the medical record entries from one interaction with the patient with a clear time and setting. That gives the documentation a solid anchor and keeps it clinically usable. Because episodes are comparable units, they also support meaningful comparisons of outcomes, quality, and cost across patients. That's the basis for improvement work and value-based care. Taken together, it is how structured EHR data becomes actionable knowledge for decisions, follow-up, and continuity of care. Now that we have covered the basic architecture, we'll move to the logical data model. Here is the logical model as an entity relationship diagram. The point is to make the key entities and links explicit. A patient and a healthcare provider meet in a contact. A contact is one care encounter with a clear time and setting. An episode of care represents one problem or diagnosis. It's anchored by the first contact related to that health problem, and it can span multiple contacts over time. Because a patient can have many episodes and a single contact may address more than one problem, we use partial contact as the linking entity. It connects medical information for a specific episode to a specific contact. The actual clinical documentation is stored as medical record entries. Each entry is associated with a partial contact, meaning it belongs to a particular contact and to a particular episode of care. Every medical record entry is organized under a clinical section, and it can be linked to terminologies. The diagnosis and problem list is a derived view, providing a structured overview of episodes. Now let's translate the logical model into openEHR terms. In our design, we use 3 template-based compositions. One for the contact, one for the medical record entry, and one for the episode of care. A quick clarification on wording. In many systems, an encounter is an administrative container at organization level. Solon's contact is the care encounter, one concrete interaction with the patient, and that is what our contact template represents. The clinical content is captured as medical record entries, each stored in its own composition. Within that composition, the clinical statements are modeled using entry archetypes: observations, evaluations, instructions, and actions. The benefit of separating contact and record entry is that encounter context and clinical content stay clearly separated. In addition, each medical record entry can be explicitly assigned to a unique contact. An episode of care corresponds to a health problem or diagnosis. We model each episode as its own composition, defined by a dedicated template, so it can persist over time as a single source of truth. The key challenge is the relationship. Each medical record entry needs to be linked to the relevant contact, and the same entry must be assigned to at least one episode of care. Now we move from the logical model to the openEHR implementation. In the next section, we will look at the templates we need and how we handle the relationships between them. Before we define the templates, let's quickly recap the basic structure of openEHR. In openEHR, there is one EHR per patient. Clinical data is stored as compositions. To organize compositions, openEHR provides a directory of folders, which allows you to structure content without changing the data. We'll start by modeling 3 templates: contact, episode of care, and medical record entry. All model templates are available on GitHub. The link is shown on this slide. We start with the contact or care encounter template. This template captures the context of a single interaction with the patient. We use the encounter composition as the container. Within it, there is a set of archetypes and clusters, for example, reason for encounter. Depending on the use case, the administrative encounter can be handled in an external administrative system, as a separate administrative template, or embedded within the contact itself. The XDS metadata cluster can help align the contact with external administrative context where needed. Now we move to the episode of care template. The container here is the problem list composition. The clinical core of an episode, however, is captured by the archetype evaluation problem diagnosis. That archetype represents an actual health problem or diagnosis we are tracking over time. Around this core, we add clusters such as problem qualifiers and clinical evidence to capture key attributes and supporting information. In practice, the data fields in problem and diagnosis archetypes are not used consistently. That makes it hard to rely on those fields for a stable episode view. That's why we introduce an episode of care header as a dedicated cluster. It stores the key episode attributes in one obviously place. The problem diagnosis archetype still carries the clinical detail, but the header cluster provides a consistent set of episode-level attributes that you can use for navigation, filtering, and longitudinal views. We won't go into all medical record entry templates in detail, because they follow familiar openEHR modeling patterns. The one exception is the progress note, because it plays an important role in an episode-oriented record. In this approach, progress notes follow the SOAP structure as described by Weed: subjective, objective, assessment, and plan. It's a simple but powerful way to capture the clinical story, what the patient reports, what we observe, how we interpret it, and what we plan next. We use the encounter composition as the container. Within it, we use the SOAP section to structure the note, and we capture the content with the progress note archetype under each SOAP heading. Now we have the templates. The next step is the high-level organization. We need to express the relationships between contacts, episodes of care, and medical record entries. The openEHR specification gives us three main approaches for that: folders, links, and cluster-based references. We will go through each option. Let's start with folders. In openEHR, folders are not clinical content. They are a directory structure, a versioned index that helps you organize and navigate an EHR. A folder tree contains folders and subfolders, and each folder holds references to compositions rather than copies of data. That means the same composition can appear in more than one folder if you want different views. Here's the same concept in a more technical view. This is an example of a folder structure as it appears in the openEHR directory. We zoom in on the top-level directory folder. In openEHR, folders are archetypable, which means you can store structured, queryable metadata directly on a folder. So the directory is not only a navigation tree, it can also carry standardized metadata per folder, while still acting as an index that references clinical content rather than duplicating it. Next, we look at the concrete folder. A folder can reference medical clinical content at two levels. First, it can reference a composition as a whole. Second, it can point more granularly to a specific archetyped element inside a composition. That distinction matters if you want to represent an episode-oriented view using folders. Technically, references to compositions sit in the items list, and references down to archetype paths within a composition can be captured in the folder's details. So with folders, you can build a navigable structure either at composition level or with optional deep links into the structured content. With this in mind, we can now use folders to organize an episode-oriented medical record at high level. At the bottom, you can see the three types of compositions we have modeled: contact, medical record entry, and episode of care. In the blue area above, we now build the folder structure in the EHR directory. First, we create a folder for contacts. Then each individual contact is represented as its own subfolder. Next, we do the same for episodes of care. We create an episodes folder, and each episode is represented as its own subfolder. We can apply the same idea to clinical sections. We create a clinical sections folder with a fixed set of subfolders, one folder per section. First, we link the contacts. Because folders are archetypable, we can store an explicit reference in the folder that points to the composition representing that contact. Each composition containing a medical record entry is then referenced in the corresponding folder. For episodes of care, we do the same. The folder created for each episode is linked to the composition that represents that episode. The association of a medical record entry to an episode is done at archetype level. Each relevant entry archetype is connected to the corresponding episode. For the clinical sections, we use the same approach. The association is made at entry archetype level. Now let's move to the second approach for relationships, links. Link is an explicit typed connection between two items in the openEHR record. The important point is where this lives. A link is not defined in the template. It's created at runtime in the openEHR reference model when the data is committed. So templates define the structure of the data, and links are added afterwards to connect the right items. A link consists of three elements: meaning, type, and target. You can link the composition as a whole, so you point to the document container. You can link to a specific version of that composition, so the reference is fixed to an exact snapshot. Or you can link directly to an entry inside the composition using an openEHR pass for more granular precision. With these three options, we can connect a medical record entry to the relevant episode of care. The link can point to the episode composition or to a specific version. To support navigation from either side, from the medical record entry to the episode or from the episode back to the entry, we can store the link bidirectionally. This gives you both views without having to infer relationships. In the same way, the medical record entry is linked to the corresponding contact. Here as well, a bidirectional setup is recommended, so you can navigate reliably in both directions. Now we move to the third option, using clusters. Instead of adding links at runtime on the reference model level, we define cluster archetypes that contain the link elements as structured fields. We create a dedicated relationships cluster for each of the three templates: contact, medical record entry, and episode of care. These clusters are then added into the respective templates, so every instance has a consistent place where relationships are captured, using the same structure every time. Here you can see the relationship cluster for the contact or care encounter. Here is the relationships cluster for the medical record entry placed at entry level inside a clinical composition. It has the reference to the contact or care encounter and the reference to the relevant episode of care. In addition, we can capture the assigned clinical section. For the episode of care, we also define a dedicated relationship cluster. This cluster holds references to the relevant medical record entries that belong to the episode. It can also capture additional clinical relationships. For example, whether a diagnosis is primary or secondary, or in the case of a recurrence, a reference back to the original episode. So the episode doesn't just store the problem itself. It can also carry structured links that describe how related entries and related problems fit together. Here you can see the same approach with clusters shown graphically. For each template, we add a dedicated relationship cluster in a consistent place, either at composition level for the contact and episodes of care, or at entry level for the medical record entries. The links are also bidirectional. That means you can navigate from an entry to a relevant episode or contact, and equally from an episode or contact back to the associated entries, without having to reconstruct the relationships afterwards. We have now seen the main options for modeling relationships. Each approach has strengths and trade-offs. The best choice depends on the specific use case and environment. To support a structured decision, I have collected criteria for an evaluation framework. It lists some of the key aspects you typically need to consider. The folder-based approach is closest to the openEHR specification, but at the moment it comes with some technical limitations in practice. In addition, the required relationships cannot easily be enforced as mandatory. If you want to enforce the high-level organization consistently across all applications on the platform, the cluster-based approach is currently the method of choice. In that setup, the relationships can be made mandatory, so every relevant entry is always assigned as required. It would be great if the openEHR community adopted this high-level organization of clinical documentation and proposed a consistent implementation, both technically and through a clear implementation guide. Here are the main documents and links related to this tutorial. All documents are also available in the download section of our website. Thank you very much for your attention. I hope this tutorial was useful and practical. If you have any questions, please feel free to get in touch with me.